and present Dr. Boaz. Dr. Boaz is one of our residents. We have a collaboration program with the Mount Sinai Hospital in New York City, with the Elmhurst Hospital in Queens, the trauma center, and we train our residents over there. So Dr. Boaz is right now in this 1 year of exchange program. So he will present a case that he managed when he was still in Jerusalem. So Dr. Boaz, the stage is yours.
Can everyone hear me and see the screen?
Yes, sir.
Yes, okay. So hello everyone, good morning or good afternoon, wherever you're at. In this coming session, I would like to present this case of severe pediatric multi-trauma and to discuss specifically this question of when should we stop that was raised along this admission, prolonged admission again and again, and I think it's a good issue to discuss with you. As usual, this case, which happened 9 or 10 months ago, started overnight around 3 a.m. Severe motor vehicle accident. The 12-year-old male was backseat passenger restrained. You can assume that the extraction from the car was prolonged and took about 40 minutes to extract him from the car. He was unconscious on the scene, unresponsive. He was intubated on the scene. Multiple injuries were noted by the EMS. He was cardiac tachypneic, got some sedation, and they brought him in the trauma bay as soon as they could. On the trauma bay, the primary survey was, we confirmed the endotracheal tube placement. We had the bilateral breath sounds without any chest deformity. We ended up putting in bilateral chest drains due to ongoing shock, but otherwise no chest deformity. We put a couple of IV access and transfused with multiple blood products since he was in severe shock, heart rate of 150, blood pressure of 50, of 130 initially. His disability score was GCS of 3. Pupils were initially reactive and equal. On exposure, he had multiple injuries, head injuries with left ear hemorrhage, active hemorrhage, lower abdomen seatbelt sign, deep lack of the perineum without any blood on BRE. He had open fractures and severe deformities of the bilateral lower extremities, the femurs, and the left tibia and fibula, and his FAST was negative for free fluid. So this sketch shows like the major injuries we saw on exposure. And after chest drains, this chest X-ray shows the drains inside, no severe deformities or fractures of the chest, no pneumothorax or hemothorax on the chest X-ray. Pelvic X-ray was positive for midshaft femur fractures bilaterally, but no clear pelvic fractures. The initial vein blood gas was not that bad actually, with pH of 7.36, base excess mildly elevated, lactate of 2.6. So we transfused him and he was responding transiently at least. We put an OG tube, put a Foley catheter, did a skin traction, and since he responded, there are some question marks, but I guess most of you would take him to the CT scanner and not to the OR at this stage. That's what we did. So we took him to the scanner, and the findings were, as noted here, from head to toe, left parietotemporal subdural hemorrhage with a midline shift, bilateral lung contusions, left zone 3 retroperitoneal hematoma, bilateral mid-shaft femur and tibia fibula fractures, and the bilateral runoff showed that the tibialis anterior was the only vessel distal to the clyteal artery trifurcation on the left lower extremity. Some pictures from the imaging, you can see the subdural hemorrhage on the left with the midline shift. And here you can see the left retroperitoneal hematoma with no active extravasation from the vessels. In this stage, we decided to go to the OR with the neurosurgeons for a decompressive left hemicraniectomy. I should be said that during the operation, his left pupil was actually dilated, so it was worsening from the initial presentation. The findings of the neurosurgeon were dismal during this hemicraniectomy. They were impressed by severe brain edema and absent brain pulsation. But during the hemicraniectomy, without any clear or obvious reason, it deteriorated hemodynamically, actually collapsed without any clear signs of bleeding. So the chest tubes were clear, no bleeding from the extremities, but the abdomen did distend a little bit. And then we took his blood gases and everything went worse. The base excess bumped, the lactate bumped from 2.6 to 4.2, the pH dropped to 7.2. So something was going on. So what would you do now? Here, maybe I would like to hear some comments from the audience. Would you take him to laparotomy right now? A preperitoneal pelvis packing, a bilateral lower extremity X-fix, maybe to reposition the chest tubes or pericardial window, although we didn't see any pericardial fluid on the FAST.
We'll go to Iraq, Dr. Untrat.
Yes, very, very sad case. I think the treatment up till now, or the patient's condition up till now, the prolonged hypotension, the blood pressure systolic of 50 on arrival, and then hypotension again, those two episodes portend a very, very poor prognosis for recovery of from a brain injury. So the priority has to be to get the blood pressure up to preserve cerebral perfusion. And from what the neurosurgeon observed at the craniectomy, it looks like it might be a little too late for that. But in deciding, I would repeat the FAST exam. I wouldn't, if you don't see a pericardial effusion or a hemoperitoneum, I wouldn't do the pericardial window or a laparotomy, but I would consider packing make bilateral groin incisions and put packs in the retroperitoneum if the patient is bleeding from there. That would be the one thing that you could do to help stabilize his hemodynamic condition, possibly bring his perfusion pressure up. You've already reduced the fractures with the skin traction, so I think that likely will take care of the bleeding into the thighs. But I think the only positive source of bleeding that you have is the retroperitoneal bleed. And I take it there wasn't a lot of blood at the scene from the pictures. It's hard. Yeah, it looks like there wasn't definitely a lot of blood at the scene. So it might be a retroperitoneal bleed, and I would consider that. The other issue is whether, with a worsening edema, he would be hypotensive. I think that would, if it's just a neurologic injury, that would tend to make him hypertensive and bradycardic. So it sounds like a hemodynamic problem. And I would consider that, the bilateral groin incisions and retroperitoneal packing.
Okay.
Thank you, Dr. Untrat. I'm sorry. Go ahead, Dr. Frisby.
I'm sorry to bother you. I know I'm just observing, but I got to.
No, sir. By all means, go ahead.
I ask a question. Sorry.
Please.
It's
No,
just
go ahead, please.
Boaz, what was the CPP at the time?
So they didn't measure it at
Oh,
this
they didn't.
time.
Okay.
Yeah.
All right. That's fine. Okay. Sorry.
All right, yeah, just as an aside, Dr. Frisbee, feel free to jump in whenever you wish. Dr. Collet in Sao Paulo, your comments, please.
So I agree with the comments. In these situations, you can find where is the patient is bleeding again. Is the hemorrhage, where there's runs of the hemorrhage. Sometimes sometimes I see people that you can see in the initial assessment, you can find hematoma in the pelvis, and then we can start with bleeding on the abdomen, on the chest. And sometimes some hours after the recovery, you can see it. So in this moment, I agree with them. It's very important to make another ultrasound or another CT scan to see where is the bleeding coming or not coming, because sometimes maybe an inflammatory procedure do the shock to the inflammatory of the trauma. So in this moment, I go to try to make a exam to see if possible where is the bleeding is coming, and sometimes I can go to pre-packing pelvis to stop bleeding, because the hemorrhage says where is not can fix it, because the lower extremity you can reduce, you can fix it, it can diminish the bleeding, but the pelvis not. So in this moment, if you don't have, I go to pre-packing pelvic. Okay.
Thank you, Dr. Collet. Philadelphia, Dr. Alex, your comment, sir?
It's a very difficult situation to manage here. I agree with all the comments that were made. I would restart with the ATLS kind of ABCDE from top down. I would, work on, preventing hypoxia and hypotension. I wouldn't stop now. The patient is in the operating room. You did the compressive craniectomy. The head CT scan did not look concern for an anoxic brain injury like that, salt and pepper kind of mixed together. So I wouldn't stop now. If the abdominal fast, part of the repeat ABCDE and, kind of going through the motions with the ATLS, if that shows blood in the abdomen, probably the next thing would be to do a laparotomy, as long as he's not bleeding out from the open fractures and you don't have anything else going on. If the fast is negative, I think preperitoneal packing may be the next thing to do, because you do have a significant finding with that zone 3 pelvic hematoma. Another option for the zone 3 retroperitoneal hematoma may be a REBOA, put a balloon and then kind of, go from there after you pack. If it's still hypotension, still worry about that. But these are my comments. Thank you.
Thank you, Dr. Alex. Let's go to Ryder. Dr. Ginsburg?
Yes,
Dr.
one second, 1 second.
Yes, sir.
So basically what I would do, anytime I take a patient to the OR for pelvic packing, I always make a small ELAP incision to rule out any intra-abdominal injury. And I don't do a complete ELAP incision. I just quickly make a small incision, make sure there's no bleeding, just exsanguinating, and then I go down and pack the pelvis. It literally takes just a couple minutes to rule out intra-abdominal. In this case, you could even run the bowel. If there's no bleeding, then do your preperitoneal packing and then come back and you can run the bowel for acidosis. So in this kid, I think you're committed. You've already gone all the way. One other comment I want to make is I have great respect for my neurosurgeons, but as Alon probably would attest to it, and Antonio, here at our institutions, we've had patients where the neurosurgeons say that they're unsalvageable neurologic injuries, and we've had a handful of patients that have actually recovered and have recovered very nicely, responsive, walking out of the hospital. So in this kid, who's 12 years old and you've already committed, I would continue.
Thank you very much, Dr. Ginsburg. Dr. Gabara, your comments, please. You're muted, Dr. Gamara. Okay, Dr. Martos.
Yeah, I agree, Dr. Ginsburg. So in this patient, should keep following for bleeding. So I do the same. I do a supra umbilical incision to see some bleeding, rule out any splenic injury, any bleeding in the cavity, run the bowel. And then if needed, I do a standard infra-umbilical incision to do a pre-peritoneal packing. And I'm gonna go from there.
Okay, thank you, Dr. Martos. For Dr. Boaz, I have a question here in the chat that from Dr. Hakim that was directed to me. I think it was for you. Wants to know, was the child hypothermic, resistant to resuscitation, if no evident bleeding?
Sorry, say it again. I didn't hear.
Dr. Hakim sent me a chat that I think was directed to you.
Yeah.
His question is, was the child hypothermic, resistant to resuscitation, if no evident bleeding?
So it was borderline hypothermic. It was around 35.6 Celsius during this stage, if I remember correctly.
Okay, Dr. Hakim, does that answer your question, sir? Okay.
Yeah, thank you, good.
Yes, sir, very welcome. Any other questions before we return to the presentation? Okay, go ahead, back to you, Dr. Boaz.
Okay, so as I mentioned, we were concerned of this hemodynamic deterioration and abdominal distension that worsened throughout the course on the OR. So we decided to do an X-lab. We saw an expanding retroperitoneal hematoma on the left side. We explored the hematoma and had to ligate the left internal iliac artery and the left common iliac vein with immediate improve in the hemodynamics and no significant bleeding afterwards. So it was controlled. Otherwise, the laparotomy was negative, no other insults. Then afterwards, the orthopedic surgeons did a bilateral lower extremity X-fix. We closed the perineal lac and took him to the PICU. He was transferred stable to the PICU, but on post-operative day 1, we had ongoing issues with his left lower extremity, progressive diminution of the left ankle pulses, progressive acute kidney injury, and ischemic hepatitis, and ischemic leg that evolved throughout the day. You can see the numbers, pretty impressive. The creatinine bumped from 0.6 to 2.6. Liver enzymes up to thousands, 10,000s, and CPK bumped almost 40,000. All signs of ongoing ischemia. And the leg, that's how it looked like about 24 hours after the index operation. So we had to do a BKA on this left lower extremity. After these 2 operations, he had some stable days in terms of hemodynamically stable, but severe injury, severe neurologic disability, a GCS of 5T off sedation, just withdrawing to pain. We completed an MRI of the brain. It showed diffuse axonal injury. We had to put a trach. Since his AKI was ongoing, we had to put him on hemodialysis. He was able to tolerate tube feeds, but otherwise everything was dismal during this stage. And it was more or less stable without any improvement for 2 weeks, until 2 weeks exactly after the index injury. We noticed an abdominal distension and he stopped tolerating tube feeds. So we rushed him into the CT of the abdomen, and we were surprised by these findings. So this is his upper abdomen on the CT. You can see diffuse infarct of the left hemiliver, the left hemiliver, the stomach with 3 perforation, and the spleen, which is actually like vanished. No spleens, all infarcted. Here we were so surprised by the findings, and what would be the etiology, the sound etiology for these findings. Was it a prolonged shock during resuscitation and the prolonged extraction? Is it a celiac axis distribution Shaare emboli? When we took a look back at the index CT angio, there might be a clue for narrowing of the celiac trunk on the takeoff. You can see it here. So this is probably the etiology for this, but it's just an assumption. Anyway, this was the second, I would say, major junction in terms of decision-making, what to do next. We have this kid, severe neurological disability, no improvement of sedation 2 weeks after index injury, and these catastrophic findings on upper abdomen CT. What to do now? Laparotomy, just palliative care, consult ethics committee, let the family decide what is the life expectancy of this poor kid.
Thank you, Dr. Boaz. Bangkok, Dr. Supa, thank you for joining.
So, Gary, if I can say now one comment. So, Iki, now the ball is in your hands. So, the neurosurgeon did their job, okay? He also already has a hemicranectomy, but now we should decide if this kid has a prognosis or not, if we should continue to treat him, or since he has a severe neurologic disability, probably this is the sign to say, that's it, we're stopping, just palliative care, and we're not sure exactly what is life expectancy. And this is the very hard question that we also didn't know exactly what is the answer, and we want to ask the participants. If we can say that, if I can add, that the participant can also say what they think the etiology is, because the shock was 2 weeks before he stopped tolerating these tube feeds. So he tolerated tube feeds for 2 weeks and then developed this picture. So we're until now we're not certain what was the etiology of this finding in the CT scan. So if the participant can comment on this also.
Thank you very much, Dr. Schwartz. Bangkok, Dr. Supa. You're muted, Dr. Supa. Okay, there you go.
The key prognostic factor for this kid is a neurological condition. And we should talk with the neurologist whether or not the kid is going to recover neurologically. And I think because in this case, it is a kid, we should talk thoroughly with the family and let the family decide to whether or not to continue the treatment. But if there's still some hope in neurological recovery for this kid, I think we should do whatever we can. If the patient is having sepsis in the abdomen, we should try to open the abdomen up and try to reset the dead bowel, reperfuse the remaining bowel, and try to support the organ failure to see whether or not the brain will come back. But it's a difficult situation, and we should talk sincerely with the family about the outcome in this patient. Thank you very much.
Thank you, Dr. Supa. Ryder, Dr. Ginsberg, your comments, sir?
1 second. So my comments is, this is like the nightmare for any physician with a young kid like this. One, I agree, you need a full discussion with the family, but at the same time, that discussion needs to, you need to guide the family and give them really the picture of, if he ends up with short gut, then that means, the chances of him recovering any quality of life, and then he's not going to be if his neurologic remains so poor, he's not going to be a small bowel transplant. So in this case, I would talk to the family and give them my recommendations that it might be better to just comfort measures at this time.
Thank you very much, Dr. Ginsberg. Philadelphia, Dr. Alex, your comment, please.
I agree with all the comments. I mean, his recovery will be dictated by the neurological status. However, his neurological status would not get better with all that, dead tissue inside the abdomen. So definitely I would involve the palliative care team, have a full discussion with the family, help them and guide them through the decision that will need to be made. With regards to life expectancy, I mean, I don't know how many cases like this are. It's hard to kind of say, hey, for sure he's not gonna I don't know, really poor prognosis overall, but I don't think there's really any big data out there saying this is what you need to do and this is what you should not be doing. We also factor in how would you feel as a physician? Like, did you give everything, all the options, all the opportunities? And I think that's the case here. They were given. So withdrawal of care and comfort measures is not unreasonable. With regards to why all this tissue became non-viable and necrotic, I can only speculate on this. Maybe an undiagnosed hypercoagulable state. I don't know anything about the kid's prior past medical history or family history, but definitely the seatbelt sign that was described in the initial presentation, may cause some blunt trauma and probably some sort of intimal flap that later down the road progressed into this complete ischemia. You have a lot of collateral between celiac axis and SMA, so you could tolerate 2 feeds for some time until this kind of becomes the way it was seen on the CAT scan. Thank you.
Thank you, Dr. Alex. Sao Paulo, Dr. Calais, your comment, sir.
At the moment, I agree with the comments. I believe that patients need to make a discussion with all the doctors that are working with them to decide what's the prognosis of the patient, neurologic, abdominal, and also muscular prognosis. And then talk with the family to try to explain what's the problem, and then to try to agree with the comments that at this moment the patient needs to be a comfort. But I don't know why the reason that they make these infections in the abdomen, these thrombus infections, because you can see air in the liver, air in the spleen, so maybe infections. Sometimes this patient may be some embolus or maybe from the heart, because this patient maybe have a cardiac injury, maybe a heart, maybe embolus from the catheters or infection association with the catheters can maybe disappear more embolus and can come this patient. So there's some cases that can work like this. If the family and the doctors decide, I can try to make laparotomy and other procedures to try to help the people, this child. It's very difficult when you see the child to make this decision. Sometimes it's very, very difficult for all people and the family to make this decision. So it's very, very, very difficult. So I don't know how to do sometimes in this moment with talk with the family.
Thank you, Dr. Calais. Iraq, Dr. Untrak, your comments, sir.
Yeah, so a difficult situation, and I agree that what really is important here is balanced, informed consent to the parents so that they have an accurate assessment about the situation and the likelihood of the different outcomes. So as Dr. Ginsberg said, they've had a handful of children where the neurosurgeon has said that there's no likelihood of recovery, and then they have excellent recovery, if not full recovery of neurologic function, that the parents need to know that children are resilient that they've seen that happen. So if you can intercede in the other reversible insults, and the one in the abdomen looks like, as bad as it is, it might be reversible if it's limited to the lateral left part of the liver and perhaps the whole stomach and spleen are infarcted, you can debride that dead tissue quickly. That'd be a very quick, a relatively quick laparotomy to remove the dead, that piece of the left lobe of the liver, and then the spleen with the stomach with a couple of clamps, it would come out and, relatively quickly. I've seen that in cases where somebody drinks lye and the whole stomach is infarcted. It's a very quick gastrectomy, and then you can close the distal esophagus around a Foley catheter, bring that out for drainage, staple off the duodenum, leave the feeding tube, assuming that there isn't, that's the extent of the injury. I would consider doing that, and then that would give the patient the best chance to recover if he's going to recover. My own feeling in handling these difficult cases is that if you give the patient the benefit of the doubt in cases where the family is inclined to try and proceed, that I think it'd be unlikely that you would prolong the inevitable if you were not going to recover. If you didn't recover neurologic function, you always have the option to withdraw treatment and provide palliative care. But I think it's very, very important to be sure that the family is making an informed decision rather than deciding for them and then shading the discussion to say that, oh, they never recover. This is, it's a lost cause. We should stop right here, because we don't know. And so the disadvantage of being aggressive is that it might prolong the inevitable, but I think you can deal with that downside. And then if you've had those miraculous successes with brain-injured children, I think it'd be worth it in this case, and then the family can make an intelligent decision.
Thank you, Dr. Intrak. Back to Ryder. Dr. Martos, do you have a comment, sir?
Yeah, this is a terrible situation. And there is a fine line between what you should say to the family and the decision that the family needs to make. I believe that we need to give all the information to the family and the technical part of that, because the family, they could be in shock in a situation like that. Most of them, they don't have any medical knowledge, so they need to trust in somebody to make decision. And you need to. It's not that you need to tell them to stop. It's the time to stop or make decision for them, but you need to give them all the substract to make the decision. Because we cannot just say, "Oh, this is your decision." It's not fair to a family to say. To be the one responsible to stopping something with a kid like 12 years old. It's a fine line. Sometimes better to have like a third person, there may be ethical committee or palliative care people, or somebody that is not so involved in the case, because for sure the surgeon going to be very involved in the case with the family, to have like a clear vision of what's happening and to help both the trauma team and the family to make decision. But again, I don't think it should be a 100% family decision. There should be something, because they may make a decision now and regret in the future, and they cannot live the remainder of their lives with thinking about if it was the right decision or not. And remember, a lot of people in these moments, they're looking for a miracle. It doesn't matter what's their religion or faith, but they look for a miracle. They have their hopes, and they say, oh, they didn't hear from one case that happened and the patient recovery after. So they're looking for to be the 1 in 1 million. So it's a very tough case. And what I would do in this situation, not have only the trauma team or the people that are involved in the case, emotionally involved in the case, and the family. I would have somebody else. Like I said, if the hospital has an ethical committee or palliative care team, just to do ask for other people to do a meeting, review the case, and help the physicians and the family to make a decision about that.
Thank you, Dr. Martos. Do we have any other questions or comments before we return to Dr. Boaz?
It's Dr. Schwartz. I can add another
I had
comment.
one question. When did this occur? How long ago?
About 9 months.
9 months, yeah.
Okay. No, because I was going to say if it was during COVID era, obviously you'd be screening them for hypercoagulability from COVID.
It was before the COVID era.
So if I can add another difficulty, there were no parents. The mother died in the accident and the father was intubated. So we had no parents even to speak with. We had just the grandfather, who was legal guardian, but also it was very hard for him to take any kind of decision. We basically had to take the decision for the family. And it was very hard for us also. There is a law, the law in Israel says that if the patient has life expectancy of 6 months, you should continue treating. But if his life expectancy is less than 6 months, you can just withdrawal of care or just do a palliative care. And for about 2 days, this was a POD 14. About 2 days, we didn't do anything. We just did all this committee. We said with the grandfather, we said with us, with the, as Dr. Marto said, with physicians that are not connected to the case, not with surgeons, and asked them also what to do. We involved also ethics committee, and we took all the information that we could to make a decision. And now Elad, Dr. Boaz can continue with our decision.
Yeah, so it was definitely not a straightforward decision at that stage. But luckily, as Dr. Schwartz mentioned, a couple of days after the scan, there was a slight, but significant improvement in the neurological status. GCS improved, he opened his eyes to pain, and I think that convinced us to explore and to take him to the OR. So that's what we did. We took him for an X-lap, and the findings were, as you were impressed from the imaging, necrotic spleen, necrotic left hemilever, and the posterior stomach wall, which was also necrosed, and with a large perforation. Otherwise, the right hemilever and the small and large bowel were intact. I will show you some pictures from the operation. Here you can see the infarcted left hemilever. You can see the colon is a bit dilated, but looks normal. The anterior stomach wall is intact. Same you can see here, but when we dive deeper, so this is the spleen, the infarcted spleen. This is the wide open stomach, posterior stomach wall, which you can see here, wide open. So we had to resect, obviously we had to resect the stomach and take out the spleen. And this is the esophageal stump with the, with the nasogastric tube from above. So what will you do now? A left hepatectomy, esophagojejunostomy, a cervical esophagostomy with a feeding judge, or any other ideas?
Sao Paulo, Dr. Calais, your comments, please.
It's very difficult to decide what to do in this surgery because all things is very difficult and all the things have complications and very complicated. So esophagojejunostomy may be the procedures in this moment because you can open the mediastinum, it can be very, very sad. So, but the anastomosis is very difficult and sometimes may be open. So I agree that in this moment try to make a reconstruction the digestive tract. And I can put a esophagostomy or a plug in the cervical areas to the device, the saliva on the other problem from the anastomosis, put a feeding in a jejunostomy. And I think that if the patient says the infections of the lesions of the left lobe is association with infection, you can debride it. You cannot take no surrounds of infections in this abdomen. You can clear up this abdomen. So at this moment, I believe that can resection or debridement of the left thighs and put a drain. As that's the way I try to do in this moment in this patient.
Thank you very much, Dr. Calais. Let's go to Iraq. Dr. Untrak, your comments, sir.
Yes. Okay. So for the liver, was it was it the entire left lobe or just the lateral part of the left lobe, lateral to the falciform ligament? I think it looked like it was
It was
the lateral
exactly by the mid-hepatic vein. Middle hepatic vein was the limit of the necrosis, exactly anatomic distribution of the left hepatic lobe, the whole left hepatic lobe. The middle hepatic vein was on the necrosis, but he was vascularized. So to do a hepatectomy is tricky.
Yeah, so yeah, to resect it, then I wouldn't resect it. If it's necrotic, it's like, you know, when you get the with the hepatic artery embolized, you know, to let the other side hypertrophy for resection, you know. So I think that can be tolerated rather well. So if it's not infected, I would just leave it. If there was clearly necrotic liver that you could debride, I would debride it, leave it drain, but I wouldn't do a formal resection. For the esophagus, I would be inclined to drain it from below, basically close the distal end around a Foley catheter, inflate the balloon, and then bring out the tube through the abdominal wall, and that should control the saliva just as well without another incision in the neck, and then staple across the duodenal stump, and then leave the feeding tube. I guess the feeding tube you'd already placed surgically, so the jejunostomy. So I would leave that, and then eventually you should be able to resume feedings within a week or so. I'm also rather surprised that the 2 days of waiting, you didn't lose anything by it, that he wasn't overcome with irreversible sepsis. And but that worked out well for you. But so that's what I would do. I think you've debrided the necrotic tissue, stopped the leak, and I would expect that he would start to recover from this insult rather quickly.
Thank you, Dr. Untrack. Philadelphia, Dr. Alex, your comments, please.
More and more difficult decisions, but as I commented earlier, you know, he's not going to recover if he has all this dead tissue in the abdomen. So it was, you know, very good to just take him and address those findings. How is my question is, before my comments, how is he doing physiologically? Is he on pressors? Liver function tests are still elevated, going up, or they're trending down? And nutrition-wise, how is he doing?
So nutrition-wise, he was on a diet until that moment. So his protein and albumin level weren't so low. I don't know I don't recall the number, but they weren't so low. He was maybe on minimal pressors, but not. He wasn't like septic, or he wasn't in shock. This is why we were so surprised to find this like a dramatic finding on the CT scan, because he was tolerating feeds. He was recovering. Just the neurologic disability was the only issue with him, and the AKI on hemodialysis. This is the only active issues. So he wasn't septic. He wasn't on a large amount of pressors. That's the point of the decision.
Okay, thank you. So with regards to the liver, so, you know, this dual blood supply, if, you know, the air in the left lobe of the liver, you know, from all the, you know, that gut, that's why, you know, he had the appearance on the CAT scan. So, you know, venous thrombus, but he still has the left hepatic artery perfusing it. If the LFTs are trending down, I would probably hold off on doing any major resection, but that's something to keep in mind. With regards to his physiology, you know, that would dictate if you want to do right now, you know, esophagojejunostomy, leave drains, leave the left lobe of the liver alone, do a feeding tube and close the belly, versus, you know, resect what's dead, wash out, close the abdomen temporarily, repeat the scan with IV contrast, make sure there's nothing else that can come and bite you later, and then go back in 24 hours for a definitive procedure. These are the options. Thank you.
Thank you, Dr. Alex. Ryder, Dr. Ginsburg, your comment, please. Dr. Ginsburg?
Yes, here we go. Sorry, I'm muting. And then just wanted to know what, with intra-abdominally, or overall with the patient? Was there any signs of sepsis?
No sign of sepsis, no sign of sepsis. The abdomen wasn't like with purulent discharge or with any discharge. There was just like necrosis or ischemia of these organs. So the perforation of the stomach was contained because it was back wall, so it was in the lesser sac. So when we entered the abdomen, we saw these necrotic organs, but there was no purulent discharge or anything. And the patient, as I said, wasn't on a high amount of pressors or on sepsis.
Was he on pressors?
Minimal amount.
Minimal.
Yeah, so from my point of view, more is less. I would not go through a major reconstruction and resection of the liver for two reasons. One, he's just starting to recover neurologic function where there's been a little bit of an improvement. So I would rather not have a major liver resection with another episode of hypotension, which would possibly deteriorate his neurologic function. As we all know, hypotension is one of the things you're trying to prevent. At the same time, you also don't want infection and hyperthermia, but I would not do a major reconstruction right now. And that's basically really what my thoughts on this case. You can always come back for reconstruction. And with regards to drainage of the esophagus, yeah, you could do an esophagostomy on this patient, or possibly leave an NG tube in. Esophagostomy is really, as we rarely do them anymore. So that's a decision that you can make. And then, in a few days when he's doing better, or a few weeks, you can come back and reconstruct him, or 2-3 weeks if he's really doing better.
Thank you, Dr. Ginsberg. Let's go to Bangkok. Dr. Supa, your comments, please. You're muted, sir.
I agree with Dr. Ginsberg, not to perform any major surgery at this point. We should do damage control surgery for the sepsis in the abdomen, resect the dead tissue. For the esophagus, you can either do the esophagostomy or put the tube in at the distal end and bring it out to divert the saliva. And for the bowel, I think I would just put the feeding jejunostomy. It would be life-saving for this patient to have distal feeding. And for the liver, I would not touch the left lobe liver at this point because it's going to create a lot of raw surface and inflammation from the surgery. And if he gets better with this, we can wait and do the second or third operation to reconstruct everything later once he recovers physiologically. Thank you very much.
Thank you, Dr. Supa. I see the wheels in Dr. Frisbee's head turning. Didn't know if you wanted to comment.
I have to go along with Dr. Ginsberg and Dr. Suprick. I don't think you need to do any kind of definitive anastomotic repair at this point. I think this kid needs to recover a little bit. And it's very curious. It almost looks like a low flow state to the posterior aspect of the stomach, the spleen, and the other structures that are involved. And I think that's the reason why you have necrosis and no frank infection there yet. Given a little bit of time, with that much dead tissue in there, certainly you will. But it almost looks as though it was a sort of a gradual issue which took place and just reached a point where he stopped eating. That's just my observation. I don't know if it's true or not, but I wouldn't do any kind of definitive anastomosis in this hostile belly, not just yet. That's just my comment.
Thank you, Dr. Frisbee. Writer, Dr. Marshall?
Yeah, I agree with everybody. Now is the time for damage control, just control sepsis, and debride that tissue. and be safe in this situation. So if you do a lot right now, you can make just harm the situation. The patient is really fragile. So just damage control and come back later.
Thank you, sir. Any other comments before we return to the presentation? Okay, Dr. Boaz, please continue.
Yep. So I guess we agreed with most of your comments. What we did is a splenectomy. We took out the necrotic spleen. We had to remove and resect the stomach with total gastrectomy. We put a tube esophagostomy out to the abdominal wall, put a feeding wedge. We didn't want to do any hepatectomy, not to add any more burden to the operation, not potentially put him in danger of hypotension and make his situation worse. And of course, we left multiple drains inside the abdominal cavity. After this operation, a very long and protracted admission in PICU, several sepsis events, which were all managed by percutaneous drainage, antibiotics. We had to do a few relocations of the tube esophagostomy by IRs. We saw a beautiful regeneration of the left hemilever in further imaging studies that we did. I will show you immediately. He was able to tolerate tube feeds a few days after the operation, with gradual improvement in his nutritional status, as well as gradual improvement in his neurological status. Some nice pictures. This is the liver a few weeks after the operation. You can see the left hemilever regenerated almost completely. No additional signs of necrosis. And here you can see the tube esophagostomy right into the distal esophagus. Luckily, I will make it short, the upcoming 5 months. He was gradually improving. We were actually waiting for him to recover neurologically, to be able to tolerate oral feeding. And when we were impressed that he will be able to do it, we took him back to the OR. We did an esophagogy. This is the upper GI serous 1 week after we reconstructed the continuity of upper GI tract. Almost 6 months after the index injury, this kid was discharged to rehab, tolerating oral food. He came back later on for a cranioplasty a few months later, and to end this presentation with some optimistic pictures. This is him after the cranioplasty with Dr. Schwartz, and this is him with his dad a couple of weeks ago on rehab. So thank you everyone for your comments and for your participation, and I would like to hear more comments.
Thanks, sir. Philadelphia, Dr. Alex.
Oh, excellent outcome with a very difficult case. Congratulations for this presentation, Dr. Boaz. This is, I like to say it's rare until it happens to you, to get a case like this. And, personally with, pediatrics, data shows what it shows, but ultimately you have to make a decision that as a provider, you can live with it. And, I had the experience with a terrible case like this where I did everything, including clamshell thoracotomy. The patient did not survive, but at a facility where I was before, underserved area, they don't do autopsies and they do catopsy, but there was no brain injury. And, I felt like I offered everything as not having the catopsy. Everybody was saying, whoa, his brain is gone, like we should maybe not do it. But when I saw the result of the catopsy, there's like no hematoma, no brain injury, no subdural, epidural. I felt like I offered everything that could have been possibly offered. even though it was blunt, even though I was pediatric. Anyways, congratulations. Thanks for presenting this excellent case.
Thank you.
Thank you, Dr. Alex. Dr. Frisby, your final comments, please.
Very nice. Very well done. Man, thanks very much.
Thank you, Dr. Frisby. Dr. Supa in Bangkok, your final comments, sir.
Thank you very much for presenting this case to us. I think the patient has the best possible outcome. I couldn't ask for more for this patient, given the injury and the organ failures he had before. And you guys did a very good job, and I learned a lot from this case. We should not give up easily on kids. Thank you very much.
Thank you.
Thank you, Dr. Supa. Sao Paulo, Dr. Calais, your final comments, sir.
Thank you for the presentation. Congratulations for the case. Very nice case. Thank you.
Thank you, Dr. Calais. Iraq, Dr. Untrak, your final comments, please.
Yes, a very, very uplifting case, and it just goes to reinforce that we're doctors, not fortune tellers, so we have to be careful. I think we've all seen this, that sometimes someone will have a strong opinion about what the outcome is going to be, and then it becomes a self-fulfilling prophecy, and the doctors get proven right. But I think here it was a potentially salvageable case, and you're able to bring about this miracle. So I think you made very good decisions, and very, very instructive. It's another example in Dr. Ginsburg's list about a handful of cases that survive. Well, there's another one. And just a question about one of the earlier steps about the retroperitoneal hematoma that you managed with a laparotomy. Would the retroperitoneal packing have been as effective a management for that in the arterial plus venous injury? Would that have been equally effective in the situation of the pathology that you found?
So I think maybe yes. A lot of the people that perform peritoneal packing has hemorrhagic control, and then when they take the packs out, they have to go to angio to do arterial blush management. So the preperitoneal packing can manage also arterial bleeding. So as you saw in the presentation, pediatric surgery were managing the case. So I wasn't involved in the decision to go on a laparotomy, and actually I was criticizing them for not going on preperitoneal packing. But by the end of the day, they succeeded with the exploration of the hematoma and the control of the bleeding, the arterial and the venous. But I think that preperitoneal packing would do the same with the hemorrhagic control, and then you can go to angio and after you take the packs out.
If I may add something, so with regards to the laparotomy, so IR, you embolize arterial bleed, but then if I remember correctly, there was a venous injury that they ligated, so probably that was actually better because it prevented all this clot burden to propagate up and add more problems with PE, and then you have to start anticoagulation, and then you kind of end up in a more difficult situation.
So if I can, so are you saying, Dr. Alex, that the laparotomy was the better approach rather than packing? Is that the packing would predispose to those other complications?
No, the venous bleeding would stop with packing, but then when everything gets removed, IR, you embolize the artery, but then what you do with an injured vein that's with clot in it and not tied off, maybe clot can propagate, then you have big P and some other complications from that nature.
Thank you very much, sir. Dr. Martos, your final comments, please.
Yes, another great case, great management. Congratulations, Alon. And that's one of the situations you see that in kids you need to invest. You never stop to do extra work. And again, you have like sometimes rewards like that. I can imagine how happy his father is after all the tragedy that happened in his family. Great management, long-term management, difficult decisions. And congratulations again. I'd like to spend some minutes just to schedule the next few weeks of the conference. Next Monday is the first Monday of the month, when we September 7th is a holiday in the United States and in Brazil. So we may not have the conference, but the guys from Spain, from Chile want to present a case in Spanish. So I'm gonna let everybody know, if they come to a case, it's gonna be Spanish and somebody translate to English, you'll be fine. Otherwise, I'm gonna skip next week. And the 14th is a noon conference, and the 21st another conference at 8 a.m. So Supa, can you present in the 21st at 8 a.m.?
Yes,
Supa still there?
Yeah,
Yeah, he's still.
I will present on the 21st.
Perfect. Okay, so Supa in 21st. Then we may have two opens on the 14th and the 28th. I'm gonna try to have a case on the 14th from Ryder, probably because of the Riley that left had a good case ready, and then 28th we're gonna see who's gonna present. Maybe let's see if Qatar can present maybe 28th or maybe.
Dr. Antras had a case, Dr. Antras.
Yeah.
Oh yeah.
Yes, Dr. Martos, I have a reasonably good case about penetrating injury to the posterior triangle of the neck. I just need to go through the approval process at CHS at Cape Canaveral, and I should know something this week, and I'll let you know. Okay.
Okay. Let me know if you can present 14 or 28, and then you decide. Then either you and Ryder or vice versa. Okay. Perfect.
Okay, we'll do.
Thank you, everybody. Great case, great presentation, and see you guys next week probably. Take care.
Thank you, everyone.
Very good. Well done.
Dr. Boaz, congratulations. Great case. Great case.